I'm just going to test this out. Can you guys all hear me okay? Okay, good. This might change depending on where I stand. So, yeah, thank you, Vineet, for the nice introductions, and thank you to all of you for coming out tonight to learn a little bit more about the emerging role of artificial intelligence technologies in improving the scalability of mental health care delivery. So what I'd like to do today is give an overview to kind of set the stage for both Alison and Rob's presentations. And so this is going to be maybe like a 10-minute presentation. This will also give us orient us to the situation at hand. As many of you may know, about 1 in 5 adults in the US suffers from a mental disorder on an annual basis. That's roughly 45 million individuals, and about a quarter of these individuals have what's considered serious mental illness, or roughly 10 million people. Now what's really interesting though is that if you look at treatment patterns, the majority of individuals with any mental disorder do not receive treatment in the year that they're diagnosed. So the actual numbers are something like 57% of people with any mental disorder do not receive treatment. And even among people who have serious mental disorders, 35% do not receive treatment. So this leads us, we can ask ourselves, why is this the case? Is it that we have a lack of mental health providers? Is it inadequate to serve the burden of mental illness in this country? Is it stigma associated with mental illness, financial barriers, lack of access for other reasons? If we look at the angle of treatment providers, because a lot of people might assume that we don't have enough treatment providers here in the US to deal with the burden of mental illness, I downloaded some data from the Office of the Employment Statistics, as well as some from professional organizations, to look at the total number of providers that we have in the US. And what we get are these numbers, roughly. So for psychiatrists that are currently practicing, there are about anywhere from 25,000 to 38,000 practicing psychiatrists. Clinical psychologists number about 100,000 to 166,000. MFTs, or marriage and family therapists, we have about 42,000. There's a large group of people who are professional counselors, and that's like 260,000. Licensed clinical social workers make up about 112 to 124,000. And then the last group are advanced practice psychiatric nurses. Couple groups are worth mentioning here that are not listed, and one of those groups are primary care physicians. They, of course, treat the largest amount of mental disorders in terms of prescribing antidepressants. I didn't include it here for a variety of reasons, and then family medicine doctors. So if we go back to those numbers of 45 million people, adults in the US, who have mental disorders on an annual basis, and 10 million who have serious mental disorders, and you look at this total workforce, you come up with some interesting numbers. So this is a little cheat sheet for me. So if you were actually to distribute that entire burden of people with mental illness to the entire workforce, the mental health workforce, you'd have about each individual provider would need to see about 70 patients a year, which is not that much. Now, if you look at people with serious mental disorders, so the 10 million individuals, and you assume that all of them needed to see a psychiatrist, then those psychiatrists would carry a caseload of about 260 patients per year, which is also not undoable. In fact, at organizations like Kaiser, it's pretty common for psychiatrists to evaluate that many new patients per year. And if you assume that all of those severely mentally ill people needed both psychiatric and psychological clinical psychologist care, the caseload, or the number of patients that would need to be seen distributed over the providers, would be about 50 a year. So that may, those numbers sound like they're not too bad. The problem, of course, is that the distribution of mental illness and mental health providers is not uniform across the US. So you have some places where there's a higher prevalence of mental disorders and a low prevalence of treatment providers. So that's one potential problem. But to look at the bigger issue of why is it that so many people with mental disorders actually don't receive treatment, researchers have actually looked into this situation. So this is Dr. Ron Kessler. He's a sociologist over at Harvard Medical School in the Department of Healthcare Policy. He sort of made a career for himself studying the epidemiology of mental disorders as well as the social determinants of health. And he and his colleagues did two studies that were published in 2011 and 2014 to look directly at the situation. So this was the first study. This was back in 2011. This was a study that looked at a survey data from something called a National Comorbidity Survey Replication. And the second study was this one, using the World Health Organization's mental health surveys. This particular study included data from 24 different countries. And the questions that were asked is, among people who were diagnosed with a mental disorder in the last year, what were the reasons that stood in the way of their getting treatment? And what's kind of alarming or interesting about these findings is that he found that the reason that people did not initiate mental health treatment was that they had a low perceived need for treatment, and they had a desire to handle problems on their own, even when there was a perceived need for treatment. And among people who actually did start treatment and dropped out of treatment, the main reasons cited were perceived ineffectiveness of treatment, negative experiences with treatment providers, and again, a desire to handle problems on one's own. So I think this is very interesting. Another study that's a little bit more specific that I wanted to mention, this is Adam Checkroot out of Yale. He looked specifically at depression using the US National Survey of Drug Use and Health. And these were data from 2008 to 2014. The cohort was very large. It was at 300,000 people or so, 350,000 people, among which about 21,000 individuals had diagnosed depression in the last 12 months. And if you look at the reasons why people cited that they did not receive treatment, which was 30% of those individuals, what you find are these reasons. So actually in this particular study, finances or cost were a significant factor, but you'll see that there are a lot of attitudinal beliefs, and some of which are erroneous, that got in the way of people initiating treatment. One is that they thought they could handle the situation without treatment. They didn't know where to go for services. They thought they could be committed and forced to take medication. These are obviously not usually accurate. They didn't have time, they were too busy, they didn't have health insurance coverage. They were concerned about the opinion of neighbors, which I guess could be similar to stigma. They're worried about confidentiality. They thought they didn't need treatment. So I think this talk is going to be interesting because we have these individuals who obviously need treatment, the 35% of 10 million who do not receive treatment with serious mental disorders. Even among that group, a majority of people think that they don't need to be in treatment, which is kind of alarming, I think. There's a desire to handle the problem on one's own. Structural factors are also important in why those particular individuals don't get treatment, more so than in the people with mild to moderate illnesses. So some of the advantages of digital health technologies in addressing these problems, one is that smartphones are now ubiquitous, so about 77% of the US population owns a smartphone. And the neat thing about these things is you can actually bring treatment to individuals. They don't have to go anywhere. You can also educate people on the spot. Just imagine for a minute if you had native mental health monitoring and screening that were available on iOS or on Android. If a chatbot popped up daily to assess your mood, and you reported that your mood was low, and 2 weeks passed like this, perhaps that technology could then administer a PHQ-9, which is a validated instrument to look at major depressive disorder, and then provide education. This would obviously cater to people who want to handle the situation on their own, and possibly direct them to treatment. The other advantage, of course, is that digital health technologies have the potential to be scalable, and anytime you reduce or take away the human component of labor, you save a lot of money. So with that, I'd like to pass the baton on to Dr. Darcy from Woebot.